pre-design work with yourselves. And we gathered some sort of preliminary requirements on what would be expected for the Cerner build. This information provided an estimate to the design teams on the level of change which would be required and sort of formed a plan for the next 12 months, which is what we're calling phase 2 of the Cerner build. And we've divided this next 12 months into 4 cycles. So I've just put the dates up here in the top right-hand corner. And we're currently in cycle 1, which is expected to run up until Christmas. Then there'll be a break over Christmas. And then cycle 2 starts in the new year. So you may be involved again in cycle 2 when it comes to like the interventional areas. And then this diagram is just an overview of the cycle and what we can expect in terms of engagement with yourselves and the design teams. So here we are at week 5 with session 1. And then this is to just confirm the details that we gathered so far, and then gather some additional information. At the same time, we're going through this EDD escalation process, which is just the governance that we have to follow to change the name and combine into 2 core locations. And then below is the scheduling sessions, which is what Gillian referred to, which will take place tomorrow. And then we'll have a couple of weeks, and then we'll probably have another session with you all to validate. So we'll work that around the dates and times that you can manage, Jill. But that will probably be around week 7, week 8. And then after this, the build will take place by the Cerner teams. They'll do the building system. They'll do any testing, remediation that's required. And then we'll send out like a build receipt summary, which is sort of the confirmation of the build that's been validated for New St. Paul's. Are there any questions on this? Does that help clear up your questions at the beginning? Great. Okay, so we'll just start by looking at some floor plans and just confirm what we know to date. This is the floor plan. We've got the musculoskeletal pod, the outpatient diagnostics pod, the infusion clinic pod. This is the most updated room plan that I have from Art. Hopefully it's correct. And also he's labeled which clerks will be sitting at which reception desk. So we've got the reception desk here at the MSK pod and the reception desk here at the infusion clinic pod. Last time we discussed check-in and which patients would be checking in where. So we said that the patients that would have appointments within the outpatient diagnostics here would check in with the MSK patients. And then the patients that had appointments in the infusion clinic would check in over here at this second reception desk with the other infusion patients. Is that still correct?
Yes.
Great. So I will go through printers and how that will work in a couple of slides. But whilst we're just talking about check-in, I've just got an overview of all the places that the appointments will take place in the hospital. So I know that the plan is for patients to check in at their location, not come up to the 7th floor to see the pain clerks. They'll check in wherever their appointment is. So I just have the level and area, the appointment types, the encounter types that they're scheduled by, and who is scheduling these in scheduling appointment book. I know we discussed it last time, but the clerks in interventional clinic have a different Cerner position, which allows them to surgically schedule. So I just called them out because there is different appointment types and encounter types which are used for them appointments. So I'll just give you a moment to just have a look at this and see if it looks correct, if there's anything that's obviously wrong, and I'll also send it out for you as well. But it just will help us with the scheduling session to make sure we're, having the right resources available for you. Yeah, Karen, have you got anything to add?
Karen, your hand is up. Karen?
Yes.
Can you hear
Your
me?
hand is up? Yes, we can
We
hear
can
you.
hear you.
Oh, okay, sorry. Okay, so actually, like, what I just have a question about the level 7, like, the outpatient diagnostic part. So you stated as P outpatient or outpatient except procedure booked as P minor surgery encounter type. So I just want to clarify though, like, did you mean like when we do the check-in for the trigger point or Botox injection appointment with Dr. Lau, that means that we will have to change it to P minor surgery?
Well, it looks like at the minute the encounters that you're using is pre-outpatient, outpatient in complex contraception, which is in
Okay.
line with because you don't have that surgical scheduling type. But in interventional pain, it looks like they use the pre-minor surgery encounter type when there's
Oh,
procedures.
okay, that is correct then. Yeah.
So is that still the plan moving forward that they will use?
Interventional pain clinic, they use like pre-minor surgery. Yes, that is correct. But I was just like trying to clarify the P outpatient for the trigger point or Botox injections with Dr. Lau. That's the reason why.
Okay.
I just want to clarify with that point.
Okay. Anastasia?
No, I think you guys just clarified it because we want it to be the same. So there'll be
Okay.
pre-minor surgery.
Okay.
Okay. Pre-minor surgery in the future then. Okay.
And that's for the complex ones, Anastasia?
I think when we go to the new samples, they're all going to be the same. So we're not going to have any complex. It's going to be just one pain clinic. All the procedures will have the same encounter type like we currently have for the other procedures currently in interventional pain.
Okay. So is the plan to get the clerks that work in complex contraception, will they need the training to get surgical? Or would that scheduling task fall to the interventional clerks?
No, Karen, I think you took the perioperative module, right?
Yes, I did.
Okay.
Yeah, so that should be fine. Yeah.
Okay, that's great. Perfect. Thank you. Okay, so I'll just do a brief recap from last time about the core locations. So we know the 2 core locations which we have, we don't need them separate anymore, and a combined core location is required. So additionally, the complex and interventional name is no longer correct, and we're looking to move to SPH Pain Clinic. So with that, we would rename any associated build that specifically calls out interventional or complex in the name. So this is the work QM, the message center pools, and the ambulatory organizer resources. And then we also discussed the scheduling build and that this again would require updates to move away from that clinic separation. So the bookshelf was confirmed and we discussed renaming the clinic books, creating new resources and shuffling the resources between the books. So a lot of that scheduling discussion will take place tomorrow with Gillian. And then finally, we logged a ticket for a follow-up order to be available in system. So this was for the allied health team to use as they'll be on a different level to the clerks at the new site. So this has been done and it's in the system now and can be used. Is there any questions on that, what we discussed last time, or anything to add?
And Kirsty, I think you already know our ketamine patient, there's one category of moderate dose that'll be checked in the minor surgery floor.
Mm-hmm.
And then the radiology piece and the interventional floor. Just want to mention about those 2 areas.
Yep. So we've got level 5 scopes and procedures for our intermediate dose ketamine and lidocaine, and then level 3 for the interventional suites for some of the fluoroscopy pain procedures. Okay, great. Thank you. Okay, so with the change in core location, I've just got here just a visual to show you and confirm is correct of what the displays will be in Cerner. So in the left-hand column here is what our current Cerner unit description is for the 2 clinics and what the blue banner, which is sometimes a shortened version, what the display is for that. And then at the new site, as it would be combined, we're requesting SPH pain clinic, and it's just the right number of characters. It's got to be 15 characters to have the same for the blue banner bar as well. So I just wanted to show you that and make sure you're happy with that. Great, thank you. Okay, and so with that, there will be a management strategy required to make it happen in the live site, in the live system, because we know it can't take place just like the weekend before the site opens. There will be a period where this happens before New St. Paul's. So we're discussing it with the build teams to try and get what the best strategy will be, and then bring this to you. There's two options: to either retain one of the core locations and just bring all the build from the other location into this one, or just create a net new location. So the build teams are all having a look at this, they're commenting and letting us know which one would have the biggest impact and which one we should go forward with as a recommendation. So hopefully at our next session, we'll be able to bring this forward and explain it with you. But with both options, we know that we will have to decommission a location in system. So there is a process with this. We have to go in and we have to make sure that the one that's been decommissioned is empty. So they have to either discharge everything out of there or move all the active encounters to the new location. So I just wanted to make sure that you were aware of that process as well. Any questions about that, the process that we've done so far?
Is that very resource intensive, or does it take a long time to do that?
They have said that hopefully we can just do a facility transfer, so the encounters that are active can be facility transferred into the new location, and hopefully the cutover would be better with the first option, retaining one location. So rather than having to move two locations into a net new, it would be better to keep one and then just move that build into one. They're thinking it would be the interventional location that we keep because the build is much bigger for the interventional site. Okay, and also with the core build, there is a location built under interventional clinic, which is room 8037, and there's 4 beds built under this as well. So I believe this is specifically for the BMDI, the vital sign monitors, which are pre-programmed for the regular interval vital sign recording. So I just wanted to confirm, is this just the infusions that this is done for? Yeah. And at the new site, this will all get updated as part of the build. And I believe that you've already confirmed all the rooms for this with Art. Is that correct? Because I can get that information from him if that's all been confirmed.
What do you mean? All I know is we have 7 exam rooms in the MSK pod and 5 infusion pods, and these 4 core beds were supposed to move over to the infusion pod and add 1 more to that.
Yeah, so it'll be these 5 here. Yeah. Perfect.
Yeah. Whereas currently we just have 4 and 8037. Right. Yeah. Okay.
Yeah. Okay, and then another part of the shared build is the message center pools that you have. So currently there isn't any for complex pain. There's only 2 for interventional pain. You have an interventional clerical pool and an interventional provider pool. So this is if you're wanting to send a message to the pool, and then it would go to all of the members within the pool. So as the core location would be combined, it would have to be just one pool for the whole of the providers. Yeah, Dr. Osborne?
I don't, Dr. Cole is retired.
Okay.
I don't know who Hennessy Human is, and I don't know who Yasmin Messery is.
And who was it? This one, sorry, Hennessy.
And then you don't have all the physicians listed there.
Okay.
So we'll need to give you the proper list of physicians.
Okay, perfect. That's what I was going to ask. If you wanted all of complex pain to be included as well, if they'd want to be part of it, and if there were any updates that were needed. Anastasia?
I haven't a clue who this Irvin person is.
The lead.
No, nobody that I know.
Okay, so, and we'll need a lead for the provider pool as well, because there isn't anybody listed for that.
And then, do you guys know Dua, this person up here?
Yep,
the-
he's one of our casual
Okay.
clerks.
And Yasmin, was she a cast? Yarman?
No, yeah, no clue who that is.
And then the Hennessy person you don't know either.
Yeah. So maybe Kirsty, I can send you the updated clerks' names.
Yes, please. And then an updated list of the providers that need to be included.
Yeah, I'll do that.
Great, thank you. And then
And
this is just a potential
Jill, sorry,
name. Oh,
you'll
go
be
on.
the lead for the provider pool.
Yes.
Okay, thank you.
And then this is just a proposed name update because obviously moving away from that interventional. So it would just be SPH pain clerical pool and SPH pain provider pool. Would that be okay?
Mhm.
Great. Thank you.
Karen, do you guys currently use the message center? Just curious if the clerks are even using it. Karen?
Sorry, yes?
Do you guys use the message center among the clerks?
No, we don't.
The moment you walk in,
Hmm.
and you already look about like,
Okay.
unless. Nobody's like, oh, it's down.
Kirsty, do we really need to have that if the clerks are not using it?
You don't have to bring in the complex pain if interventional are just using it, or if they're not using it at all. It's fine to get back to me and let me know.
Okay, I'll get back to you.
Okay, so and again, another shared build is the ambulatory organizer. So currently your resources, you have a complex pain resource group and a complex pain room resource group. And then you have an interventional pain resource group. So your providers and clinicians that are part of the interventional pain are within this one, and your providers, clinicians, part of complex pain are within this one. But as it's going to be the joint build, we need to separate that in a different way if we don't want to have interventional and complex. So one of the ways that other areas divide their resources, if they have a lot of clinicians, is they have a providers group, like all their providers are together, an allied group, all their physio and OT are together, and then a nursing resource group. And then we could, again, just use the name SPH pain for each of these. So I just wanted to get your thoughts on that, if that was something that would be useful for the team.
Then what about the group classes?
So when I looked at this, I couldn't see any classes that were actually scheduled to this. So I wasn't sure if this was used. So I was going to ask you that as well.
I think when you say orientation room 437, I think that was for the group classes that we currently hold for with Allied Health, and also there's 2 physicians who also hold groups on Mondays.
Okay. Room 437.
Yes, currently, but in the new St. Paul's group that's happening in the class that's happening in room 437 will go to Center of Aging floor, and then the other physician led will remain in the procedure one of the group rooms on the 7th floor.
Okay. So do you like to be able to see that on ambulatory organizer?
I don't know. Why don't we, Karen, do you have a
Do you maybe any of
Or-
Allied Health use it, or?
like I don't have Allied Health here today,
Yeah,
and other clerk Aaron, he's away on vacation, so maybe Can we
Christy,
touch
it's
base
Jillian.
tomorrow?
Yeah, we were going to talk about this a little bit more tomorrow, if that's okay.
Yeah,
Yeah.
that might be better.
Yep,
Okay.
that's fine. Yep. I'm gonna mute Karen. Okay. Okay, so this is just, I'm not expecting any changes to this, but it's just to just for your validating that you're seeing it. So the clinical medical service for both clinics is pain medicine, so no changes required for that. And then this is just all the encounter types I could see that you use for both clinics. Is there any that are incorrect or any that are missing?
When we get out like data sent from other places that it's scanned in, will that, like, where does that get scanned in under?
Is that like a physician conference sort of
No,
thing?
so if physicians, like sometimes we'll have a meeting and they're off at other sites, and then that patient discussion will be faxed in from the other doctor's office, and then that will be scanned in.
Is it a case conference?
It's case conference, yeah.
Okay. Does that sound right, Karen? Do you know?
This is more for us in interventional.
Okay. All right. Okay. Check that one.
And then consent, there isn't something there that, so when we get a consent from a patient, then they scan the consent in.
Would they just scan that in to the like the minor surgery or the day surgery? Yeah.
As long as we know where it's going to be scanned in so that the nurses can find it. That's the big issue.
Should be fine. Okay, and then just for default printing as well, so it's slightly different currently in the two clinics. So the defaults that print at auto print at registration. In complex pain, you have one face sheet, one armband, and one patient form label. In interventional pain, you have no face sheets, one armband, and 4 patient form labels. So with them coming together, we just need to, we can change it completely, or we can just pick one which is required for the new site. But we just need to put in what the auto print default is. Yep, Karen.
I just want to clarify for the complex pain clinic side. Basically, we don't need face sheet and armband. We only need the patient form label.
Okay.
But if Dr. Herman Lau is doing trigger points, that patient should have a armband on.
Actually, like for this situation, people in outpatient department will deal with that. But when I was in OPD, actually, none of the nurses or the doctors required us to have, to print the armband labels.
In the new area, anyone having a procedure should be having a label on, and that's standard of practice. But we'll ignore that for now. But in the new area, they will need an armband, and we need the 4 labels because often we're writing prescriptions and stuff. So a face sheet, I think interventional, it would be better because we need those extra labels.
Okay, but nobody requires the face sheet, so we can continue with 0 for that.
What do you mean by face sheet?
It's like a sheet of paper that prints out that just has some of the demographic information on it. I don't know, Karen, maybe you'll be able to explain it better, that prints out for complex.
So basically, like this face sheet is usually printed out by the booking clerks in outpatient department though. So actually that face sheet looks like patient demographic information and the attending physician. So this is what I can remember though.
I guess, Jill, once you're in the new St. Paul's, patients will be directed to go sit in the hallway. We're not going to have anybody to be sending face sheets down anyway, right?
Yeah,
So we
and-
probably can just do the armband and the labels.
Yes, I think that's fun because the face sheet, the only time I've ever used face sheets is if we're doing a blood transfusion and we're doing checks for a face sheet for blood.
Yeah.
So or for the nurses when they're signing in for surgery, for big surgery, we don't use the face sheet check down in the interventional suite either. So I think the armband and the 4 labels is enough.
So Kirsty, can I ask you a question? When a patient checks in, it's that clerk is checking the patient in, will provide the armband. Would they be issuing the labels to the patient to bring to the physician? Is that how it's going to work for other areas?
Usually in other areas, if they print out a patient form label, there's usually like a chart prepped that they sometimes attach that to, and then that's put in a specific location. Depending on the clinic, some clinics either put it in a location and then the providers come and get that and get the patient, or sometimes clerical staff will take that to a provider's room. It's not usually given to a patient.
Yeah, because I'm just trying to figure out for the new St. Paul's how that would be, because we're not going to get the armband, everything. I guess you don't get them until you check in, right?
Yeah, when you do that registration and check-in.
Okay, well, because that's going to be then a conversation that we probably have to have with all the outpatients, because I don't see those 2 clerks checking in patients for the entire pod with multiple physicians running that down to all the exam rooms, right? So unless the patient labels and armband could be printed prior to patient being checked in, at least that could be. No, you know what? I think we need to take this offside with Art and figure this piece out.
Okay.
Thanks. Yeah.
We've still got time, so if there are any changes to this, just let me know. We don't need to confirm it and validate it today. If you want to have discussions and get back to me on the exact number of printouts, that's absolutely fine. And then the
And
same
Jill,
for the.
sorry, Jill, you're good with just 4 patient labels or less or more?
Yeah, I think 4 is good. Sometimes we need more if we're doing more than 1 prescription and we can print them out.
Okay.
As long as we have printers available like we do currently in our office, we don't really need anything else there. And those other, because we're not sending blood samples or anything like that. If we can do what we're doing with the chartlet beforehand, have everything printed beforehand, it might be expedient. But as Anastasia said, we're going to have to figure that flow offline.
Okay. And then, yeah, this is just the print label conversation, which if somebody wants to go in and specifically print something additional than that registration, then this is just the defaults that are set, but they can be changed to whatever you require to print. Okay, so just to go through the printers now. So for the new site, we know we've got 2 registration locations on the 7th floor. So there's 2 printers and 2 label printers. So 1 at each of the reception desks. And then I've also just got a little screenshot here on the next slide of the actual reception desk. So this is the reception. Oh, yeah, Dr. Osborne?
I'll let you go through, but we're going to need more than 1 printer in each of them. We're going to need print because it's so far away, so far away. We're going to need printers near where we're working for us to print off handouts for patients and more labels and stuff.
Yeah, I was going to go through that with you about the requisition printouts as well, because I wasn't sure which ones you'd be using as it looked a bit sparse. For the registration location, I'll just go through the registration ones and then we can talk about the requisition ones. But this one's the MSK pod reception desk, so you can see the 2 PCs. And then in the middle, there's the laser printer and the label printer. So I've just taken these labels that they've labeled them in red, and I've just put them next to each one of these. So this one's for the MSK pod, 2 PCs, 1 label printer, 1 laser printer. And then this one is the infusion clinic reception. So again, there's 2 PCs, 1 in pink, 1 in yellow. Then in the middle, there's the label printer. And then just to the back here, there's the laser printer. So is that okay that I've just pulled them in for the 2 registration locations and the 2 registration label locations?
I think what's already decided, but I think in terms of the label printer, having that up in the front, I'm not sure how beneficial that would be unless we're going to have a runner that's going to be taking these patient labels down to the clinic rooms, exam rooms.
Okay, so that might change. Okay, so once you've had that discussion with Art about that workflow and if we need to look at changing that label printer, we can just update that. Does that sound okay? Okay, and then narcotic printer, you currently have a narcotic printer on in interventional pain, is that correct?
We have one non-functioning one.
Okay, and at the new site, is there a plan for one, a functioning one?
I thought we asked for one. Kelly, I
You,
thought we asked for one, right?
I think that we did, but unfortunately, there's a lot of barriers with the narcotic printer, like pharmacies won't accept the electronic fax, like it needs to be manually faxed still. So it would only be something that we would be able to input on Cerner in theory, but in terms of sending a script for it to be refilled, we would have to print it, fax it manually, is what I was told.
But we're not having a fax machine at the new St. Paul's.
Yeah, so that part I'm not too sure if future pharmacies will accept it, the electronic one.
Yeah, because Kirsty, I thought we're using that right fax. Like we're not going to be using the fax machine anymore.
yeah, that is the plan, to use the right fax for e-faxing. But is that the reason why you're not getting a printer, the narcotic printer?
I don't know. All I know is we asked for one, but now Kelly says that there's different reasons why we can't get one.
Oh, so maybe I need to look into that.
Thank you.
Yeah, I think the main barrier is pharmacies that are not part of the hospital may not accept these narcotic scripts that are sent electronically.
Okay. And the physicians are just writing them out at the minute?
Yes.
Okay, thank you. So I'll take that away and I'll look into that. Is Sunquest Collect used in either of the clinics for specimen collection? No.
No.
No. And is single document scanning used at either location?
Pardon?
What is single document scanning?
It's a scanner that you'd have that you can put your documents in related to a patient, and it can be pulled directly into that patient's chart. So it's used instead of sending stuff off to HIM and HIM doing it, it can be done within the clinic.
I think they scan like our consent forms and everything like that directly into the patient's chart. So we would
Kelly,
need that ability.
Kelly, don't we have a single scanner?
For consents, I know that we're able to fax it to the clerks and they're able to populate that that consent.
Okay, so they do it that way, I see.
Yeah, so I get the patient to sign it and I give it to the clerks and they scan it directly into the chart. And same with information coming from other EMRs that comes in is scanned into the chart. So we need that ability, yes.
Okay, maybe I'll just confirm with Aaron when he's available exactly how they're doing that. Sounds good, thank you. Okay, so the medical imaging orders which you enter in system, so they're entered in system and they're entered as a future order. They're not active, you're not doing that there and then. But in terms of the printer, do they automatically print out when you put that order in?
Currently, yes, because a lot of times patients go downstairs and they tell them they don't exist. So we give them the piece of paper for the day they go in for their x-ray, and it's in Cerner, just hoping that one of them will work.
Okay. And in terms of printer for the new site, have you discussed which printer would be the best one for requisitions? I have a floor plan which Art sent me, which has some of the printers called out. So your 8 exam rooms are over here on this right-hand side. And then there is a printer here, which is in this blue square where this workstation is. There is a laser printer. But it is a bit of a walk through. So I wasn't sure if this was the nearest printer or if you decided a different printer.
I haven't been in discussion with any printer, and a printer near us is really important, especially when I'm giving patients exercises. I have to give them a piece of paper with the pictures on it. And so I need access to a printer, and I can't be walking across half the hospital all the time.
So Kirsty, I'm late with that. I know Art sent me this floor plan that you're sharing with us right now. And I don't think there are enough printers shown on this diagram. I was told that if we have printers that physicians have access to, they will at least mirror that. But looking at from the design of this floor plate, there aren't enough printers, and it's going to be really challenging not to have these installed, because I can't see physicians walking around the corner just to print stuff. Because right now they have it accessible right there, so they can just print and then they go. So like, for instance, in audiology, I requested a printer for every single room because of our needs. So Jill, we will have to probably take this offline and see at least how many we can get, maybe even if every other exam room or something, I don't know, have to figure something out. Yeah.
Okay. So we just need to know which printers you'll want as a default printer. So usually we just have one per call location as the default printer. It can be changed when the physician goes in to do the printouts, but when you're putting that order in and there's an automatic printout, there's just one printer.
Is this the only printer? Sorry.
Looks like
yeah. So this is what
for everyone. Yeah, that's not good. Yeah.
Over by the infusion pods. Like, where is it by the infusion pods?
The infusion pod is on a different one, so I've got that one up here. So there's one here at the reception desk, and then there's one here in this team room. There's a printer here, if you can see it. I know it's not great.
So just looking, they would have to walk all the way down out the corridor and then access because I'm looking where the doors are.
Yeah, there's a door here, or they can go through reception, which isn't ideal.
No. No, there has to be a printer closer by.
Okay, so do you know when, have you got meetings arranged with Art to discuss the printers, or do you know when that will be decided?
He wanted us to let him know by end of this Friday, so
Okay.
we're just reviewing everything, going from there.
Okay.
Yeah.
Perfect. Well, I'll connect in with Art as well, to keep us updated. But yeah, we do need to know that one default printer for the requisitions for medical imaging, and then it's also the same for any labs, so blood work that's printed out as well. We'd need a default printer for that. So I have the lab work slide here as well. So what they do in labs, they usually set defaults by an 80-20 rule to determine how their flexing should be done. So for the blood specimens, we currently have 80% of the time we expect collection to be done by the community or outpatient labs. Is that still going to be the case going forward? Yep. And then for non-blood specimens, 80% of the time we're expecting collection to be done within the clinics. Is that still correct for moving forward?
Yeah, if we're doing drug tests on patients for prescribing opioids, they have to be done within that clinic.
Okay.
They can't community because we have to witness.
Okay. That's great. And then again, so for that printer name, we'll just put that in once that's known. And then Lab have also said that with the combination of the two locations into one, they have found a difference in your order entry flexing, specifically to the collected field for non-blood specimens. So I just have a screenshot here to explain it. So this is both the same order, it's for a urine culture. One of them's placed in complex pain, one of them's placed in interventional pain. And then this collected field is just different in each clinic. So in complex, we have collected as no, and in interventional, we have the collected as yes. So what they're asking is 80% of the time, would we expect it to already be collected when the physician or clinician is entering the order, or are we expecting that it's not yet collected? And which way it should be flexed to?
Never even really thought about this because I just get them to pee in a cup and I fill out the form.
You can get back to me if you want to confirm it, but yeah, we just need to select which one we want to move forward with.
I don't need someone else to collect it because I always thought the collection, if I tick the collect, what is that? Collect. So that's like clinic to collect. No, that means somebody else is going to have to come collect it.
That's the unit collect one, yeah, so that's a different one. This one, it's asking if it's already been collected when you're entering the order. So you already have the sample and then you're putting the order in. Or are you putting the order in expecting somebody to then get the sample?
Jill, I think the question is, when you get a patient to do the urine culture, do you get them to pee in the cup first before you put in the order, or do you put the order in after?
I never get urine cultures. I drug cultures. So I never do a urine CNS. Or I haven't for years. But the drug ones, I get them to pee in the cup while I'm putting the order in.
Okay,
so then done simultaneously.
So then it would be yes.
Yeah,
collected.
I think we're saying yes, which is what you have for interventional.
Yes.
Okay.
But it's just if you're happy with that for it being both clinics, yeah.
Yeah, and this is just a default and it could be easily changed.
It can, yeah.
Yes.
That's correct.
Yeah.
Okay, thank you. Thanks for clarifying, Kelly. Okay, so finally, just about pharmacy. So I spoke to Kelly about this as well, and it was just about the Burrard PharmaSave. They currently prepare and deliver the intrathecal pump reservoirs. So we just want to confirm that this will still be the agreement for New St. Paul's, that they will continue to deliver.
Yes,
For
then-
now,
I've asked them.
yes. Yeah,
I hope
but-
so. We'll have to ask them.
yeah,
They said yes.
I hope so too, but they said yes.
Yeah, I
Not many
already reached out.
places compound these sort of drugs, so yeah.
Great. So just if there were to be any changes, if there was a new pharmacy that agreed to take it up upon them, then we just need to update the system. The pharmacy design team have to make some changes. So if there were to be any changes, just to let us know.
Sure thing.
Okay. So that is everything from me today. Is there any questions or comments or anything that we've not talked about that we should have mentioned?
I know Kirsty, you and I have exchanged emails, but just want to make sure that when our patients who have procedures in the interventional floor, there shouldn't be any issues with getting those clerks to check them in.
Yeah, so that's
Yeah.
in the interventional sessions, isn't it? And with Josh, the interventional sessions will be cycle 2, so that will
Yeah.
be in the next in the new year. And yeah, that's the plan that we have been told as well. They will be then checking them in.
And the scopes and procedures one where we're getting the intermediate dose ketamine as well.
And the same for the rehab appointments as well for the patients that are seeing the allied health clinicians. They'll be down on level 2. They wouldn't be coming up to check in on level 7.
But that's good for the patients.
Yeah. Okay, so all the scheduling piece, that will be with Gillian tomorrow. So I'll be there as well. I'll see some of you then. And then I'll send out a scheduling validation. I'll schedule a validation session as well. Maybe I'll just coordinate some dates and times with you, Dr. Osborne, with you being away. But please feel free to reach out in between if there's anything that comes up. And then I'll take some of that printer questions away and try and figure out some of that as well, especially around the narcotic printer. And then once you've discussed with that about printers as well, if you can just keep me updated with that.
Okay, sounds good.
Kirsty, can I just ask one question?
Yeah, of course.
So maybe this is something I need to speak to Jillian about. So currently in the pain clinic, when we do these procedures, trigger point injections, or what have you, I'm not able to pull that stats correctly because Christine Manzano's here. But when we set this up when we were doing Cerner go live, we were told that we can, but I really can't. So is this a good opportunity at this time to, when we're scheduling these patients, so we could pull those stats the way we schedule these patients in the future? For example, if somebody's coming for a block, I want to be able to capture that and pull that data.
Yeah, they're scheduled as a procedure, right? Like it's not an appointment type. The procedure name is entered as a trigger.
Yeah.
point.
But I don't think I know, like I'll never be able to find out how many sympathetic blocks did we do. Like I don't have down to that granularity like we used to have when we were using SCM. It's kind of like similar to what's happening with ENT.
Mm-hmm.
Yeah. So I'm not sure if we should be addressing that now so that we are ready to capture this information correctly for the new St. Paul's.
I
site.
see.
Yeah.
Yeah, just so you know, Kirsty, we are for ENT clinic. We're changing, like I think they have a minor procedure as the name of the appointment type, but now we're going to request each procedure name be included so that they can track the appointment types by procedures.
Okay.
So we can look into that, Anastasia.
Okay, thank you.
Okay, great. Thank you, everybody. So I hope you have a good rest of your day. And yeah, please reach out if there's any questions. Thanks.
Thank you.